Our last lecture of the day before another hands-on session is going to be the Dr. Michael Macias of the POCUS Atlas. Very excited to finally meet Mike. As I mentioned, I was at University of Kentucky, and I think I Twittered him, and I was like, "Hey, do you have any jobs?" And he's like, didn't answer for a while, and I was like, "Oh, okay, I guess whatever. I'll just try somewhere else." And he's like, "Hey, do you have time for an interview in 2 days?" And then now I'm here, by the way. So that's like kind of how I got here. Thank you so much. Mike is the ultrasound director for EMA, which is a ER group. He works predominantly out of Temecula Valley Hospital, which is where I'm at, and he runs excellent courses. All of the design for everything is actually Mike, so thank him. Also, if you don't like something, also bring it up today. He's going to talk to us today about narrowing the differential in dyspnea. Thanks, Mike.
Thank you, Jacob. And we love you at Temecula, so we're really excited that you're working with us now. So I love giving this talk right after the cardiac talk because I think when we're talking about point-of-care ultrasound for cardiorespiratory complaints, we need to be looking at the cardiorespiratory system, right? So it's rare cases that I'm doing a cardiac ultrasound without a lung or vice versa, right? They work together. So we really have to think about that system as a whole. And that's why I'm really talking about lung ultrasound today, but I'm really also going to talk about how do we narrow the differential in cardiorespiratory complaints. So just financial disclosures, I do some consult work for EchoWorks and Butterfly Inc., but I'm not talking about any of that today. So I want to start with a case. So as every ultrasound lecture starts with, generally it's a case because we want to inspire you. So I have a patient who comes in via EMS. They already have the patient on a neb. They said they're working really hard, increased work of breathing, wheezing, history of COPD. They're definitely a COPD exacerbation, right? So what else do we want to know about the patient? Anything? Maybe the exam. There's no edema. They definitely are wheezing when you put the stethoscope on. I can't really tell you much else because they're too dyspneic. So they're on the stretcher. This is actually a Temecula. They just bring them right in the door, the glass doors, and they're right there. So we just evaluate them right on the stretcher. Put the ultrasound on real quick. This is what we see. So we see these bright lines going down from the top of the screen. This is a lung ultrasound. These are B lines, which we're going to talk about. See it both sides of the lung fields. And then we put the probe on the heart. And this is bad, right? Good versus bad, we just learned, right? This is definitely bad. So we see a bad heart. We see these B lines, which represent fluid throughout the lungs. So this wasn't really wheezing from COPD, right? This was just acute pulmonary edema. So we actually just placed this patient on BiPAP right there, and we use high-dose nitroglycerin for acute pulmonary edema. We were able to basically get her from needing to be intubated to basically transition to just a nasal cannula within 30, 40 minutes. So we initially thought she was going to be ICU, but we basically downgraded her to just a med tele bed pretty rapidly because we were able to identify what's going on really quickly. So this is my general framework for point-of-care ultrasound, right? Everything we do for point-of-care ultrasound is because there's a question. So we ask, what is the question we're trying to answer that we can use point-of-care ultrasound, right? And then there's an action. So if you follow this same pathway every time, it makes point-of-care ultrasound pretty easy, right? We're always just trying to do it, to answer a question, and then to have an action. And the action's different depending on what you're doing. Are you diagnosing something? Because we diagnose things, right, with point-of-care ultrasound. Are we going to use it to order further imaging? Maybe I might ultrasound these lungs and they're clear and now I'm worried about a PE. So I'm going to get a CT, change my management. Or I'm going to adjust therapy. Maybe we have that hypotensive patient. We thought they're septic, and now we realize they actually have pericardial tamponade. So we're sometimes surprised by what we find, to be honest, but it can lead to significant changes in how we care for patients. So this is really the chief complaint that we're talking about today, right? Shortness of breath. It's such a common chief complaint, whether you're in the clinic, whether you're in the emergency room, whether you're pre-hospital. And it can be overwhelming, right? There's so many things on the differential. Pneumo, pulmonary edema, Anxiety, I'm just going to click through, right? It just keeps going, right? There's so many diagnoses that we have to think about, right? So it can really drive us crazy. So how can we use ultrasound effectively to kind of make our brains not do this, right? So what if I told you guys that ultrasound is better than chest x-ray, right? Does anyone believe me? Or okay, good. So it is true, and hopefully I'm going to help show you guys that. So the first thing, right, is lung ultrasound is highly accurate. When we look at a lot of the data, one study was looking at patients that already had diagnoses. Definitive diagnoses, gold standard, based on usually hospital discharge or definitive CT imaging. And then they went and ultrasounded them, and they looked at their different lung profiles and said, does lung ultrasound tell us exactly what happened when they were, like what their final diagnosis was? And we found that it was very, very accurate at identifying those diagnoses. So we can use lung ultrasound, and we'll get the diagnosis right at a very high percentage. We also know that it actually identifies the diagnosis way faster. So this was a randomized control study. It was actually a Danish study. They looked at people doing standard care versus standard care plus ultrasound. And at 4 hours, we knew the diagnosis at a way higher percentage by using ultrasound first, so 88% versus 63%. And then also, again, it's much faster. This was a similar study. It was actually observational. It was 2,000 patients that got ultrasounded and patients that had no ultrasound. 24 minutes to diagnosis in the ultrasound group, 186 minutes. So you might ask, does this make a difference mortality-wise? Maybe not, unless those critically ill, right? If I'm going to make a decision now and I have a sick person, I'd rather get the test that helps me and gives me it in 24 minutes than 186. So let's talk about some specific operating characteristics. So let's look at how does this test actually work, the specific test for a specific type of diagnosis. So see, these are some graphs from our evidence atlas, and we sort of look at the biggest studies that sort of group together a lot of the data we have. And this was looking just specifically at B-lines for acute cardiogenic pulmonary edema. So if we see, and we're going to talk about B-lines, if we see B-lines in multiple fields in 2 bilateral lung zones, this is probably the best single test you can use to rule in congestive heart failure, right? So 92% sensitive, 94% sensitive, 92% specific. Pneumothorax, again, big meta-analysis. No lung sliding and lack of comet tails. 90% sensitive, 98% specific. Pneumonia, this is for adults. If we see findings of pneumonia, an ultrasound will show these subpleural consolidations or focal B-lines. Again, we're going to get to B-lines. Really high sensitivity, 92%, 94% specificity. Lastly, pleural effusion. Pretty easy to see pleural effusion, right? We're really just looking for black above the diaphragm. 94% sensitive, 98% specific, right? So all really good operating characteristics, right? So I do have this available if you guys want to reference it later. The Evidence Atlas app does have all of these, and you can actually just pull them up on your phone. So if you ever want to know what the sensitivity specificity of a test is, you can actually just open up the app and review it, and it has a link to the article that the table comes from. So the other thing I love about lung ultrasound is that it's technically easy, right? We really just have to put the probe on and find the rib space, and we're really just looking underneath, right? So technically, it's a very easy exam. It's really how do we actually use that data that we see and figure out what's going on, and that's what we're going to talk about. So we're going to first start with how do we evaluate the lungs, right? So before we even start to put the probe on the patient, we need to know how are we positioning, right? So right, when we're first thinking about how we're going to position the patient, we first have to think about what are we actually looking at, right? We're going to be looking at the lungs. We're thinking about potentially pneumothorax, fluid in the lungs. So we have to remember, right, air is going up and fluid is going down, right? So depending on what we're looking at, that's going to determine how we position the patient. So I'm looking for a pneumothorax. I want the patient flat, right? Because I want that pneumothorax to rise to the surface, right? Because I want to be looking in their anterior chest, and I want all that air to go up, right? So if I'm looking for a pneumothorax, they need to be flat. You don't want to be doing it when they're at 90 degrees. Pleural effusions, right, the more elevated they are, the more that fluid's going to pool. So we want them to be seated up so that you can actually estimate the pleural effusion best when they're at 90 degrees. But generally, this is my exam, right? When I'm doing my general lung exam with dyspnea, I put them at 30 because that also allows me to do my cardiac evaluation usually and get a good estimate of their pleural effusion. So they're usually right about 30 degrees supine. So how do we actually do it, right? So this is a short video looking at how I would evaluate the anterior lung field. So we're going to have the probe placed axially, right? So up and down or parasagittal. We're going to have the marker placed towards the head. And we're really just evaluating the intercostal space. It's that simple. You're going to see they're evaluating that space. Then they're sliding down and looking down the next intercostal space. And then the next. And then they're going to move over to the lateral region. So I like to use the 6-view approach. So there's 4 per lung. There's 4 areas on the anterior, 4 areas on the anterior lateral surface, and there's 2 posterior. So if we look at this view, we break up these segments by our line. So our parasternal line and our anterior axillary line create our anterior space. Our anterior axillary line and our posterior axillary line create our lateral space. So we can then divide those into a superior and inferior section by the nipple line. So I'm going to be evaluating each one of these spaces. See if this works here. There we go. I'm going to be evaluating my anterior field superiorly and inferiorly. And then I'm going to be doing lateral superior, lateral inferior. And then I'm going to do the same on the posterior aspect, which we'll show in a second. Now that's what I'm going to do to evaluate the pleura and the parenchyma. But when I want to look for a pleural effusion, remember, this is dependent. So we're going to be looking right above the diaphragm. So we're going to be looking just like that, right? We're going to put it right along the diaphragm in an axial orientation. And then we're going to look at 2 spaces posteriorly. So I'm going to look in my left upper lung, left lower lung. Again, that same axial positioning, right, with the dot towards the head. I'm going to do the same on the right side. So these are the 3 things we're looking at for lung ultrasound. I like to break them down because we're thinking about 3 different things, right? Every time we're looking at the lung, we want to know what's the pleural line doing. We want to know what the parenchyma looks like, what's in the lung. And then we want to look for effusion. So when we put the probe on the chest, this is actually the structures we're looking through, right? This is a cadaver model, and I just superimposed the probe on there. And you can see we're going through skin, then we go through pectoralis muscle anteriorly, intercostal muscles. We can also see 2 ribs here, and then we're going to be getting to our pleura, and then parenchyma just below. And this is what we're going to see. So you guys have seen this view before. Really, the biggest things to remember, right, is for our views is we're going to be looking for a rib with shadow, pleura, and a rib with shadow. And this is the same view we're going to be seeing for all 6 of those spaces that we just talked about on each side, right? So once you know how to get this view, lung ultrasound's easy, right? And there you can see them head to head. So we're hitting rib, got pleura, and then we have another rib. And you can see there that arrow, we can see the pleura, and that's sliding back and forth. That's the parietal and the visceral pleura rubbing against each other. So remember this, right? Rib, pleura, rib, right? I want you guys to keep that in your head. Every time you're doing lung, say rib, pleura, rib, okay? And then you'll be able to find where your view is and where you're going to be looking. So again, just looking at our space, rib, pleura, rib, that's going to help us identify the areas we're looking at. Okay. So breaking down this image a little bit more, again, our pleural line is going to be that hyperechoic line that's just below the ribs, and we're looking for sliding back and forth. This is really going to be what we're looking for lung sliding. So we're going to be looking for shimmering. In the COVID era, it became really important. We started talking about the pleura a lot more because it was helpful, because we were looking for a irregular appearing pleura with defects in it that would clue us in that there's a viral process going on. The next part of it is the parenchyma, right? So the parenchyma is going to be what's going on in our alveoli. Is there fluid in the alveoli? Is there air? This is the space we're really going to be looking at to identify that. And then lastly, our effusion, we're really looking for this at that lung base, right? So remember, right above the diaphragm is where we're going to be looking for fluid. And this is what we're going to see. When we put that probe on there, we see as this patient breathes, that lung came down, and we're going to be looking to identify our solid organs. So here's liver, this is the right upper quadrant, diaphragm, the spine, and then that lung is going to be just above it. And normally, we don't actually see the lung, right? Sometimes we'll see a mirror artifact. So it'll look like there's liver in the lung, and that just tells us there's air at that lung base. There's no pleural effusion. So that brings me to the next point, right? So in order to understand lung ultrasound, we have to realize the truth. That there is no spoon. You guys are probably all banging your heads, wondering what the hell I'm talking about. So I'm trying to go a long way to tell you that lung ultrasound is not real. So hopefully now you get the matrix metaphor. So what we're seeing in the parenchyma is not actually there. We're using artifacts that are generated by the ultrasound machine to determine what's going on in that parenchyma at that time. So these are A lines. This is the first lung artifact that we're going to see when we're looking at lung, and A lines is air. So A lines are going to be, again, there's our rib, pleural rib. A lines are going to be these reverberation artifacts where we're going to see parallel lines of the pleura that are equally spaced. And what these represent is an air-filled alveoli. So when I see a lung with lung sliding and I see A lines, I know that at that space, those alveoli are filled with air. Right? And so in this image, you can actually see I've highlighted A-line pattern. So we can see the top blue line is the pleural line, and below it we see a line that looks exactly like it. And that's not real, that's just an artifact, and it tells us that there's just air there. Here's another example of A-lines. Sometimes you have more than one. You can see they're equally spaced, and they're parallel lines from the pleura. So air. And we'll see this in a normal lung. So if we were to ultrasound all of our lungs, this is what we'll see. Pulmonary embolism, asthma, COPD, anemia, anything where someone's coming in with shortness of breath and their lung parenchyma is actually normal, we'd see A lines. B lines, on the other hand, are going to be the opposite. So B lines equal fluid. So we're talking pus, water, blood, atelectasis, right? Anything that's filling those alveoli with something other than air, we're going to be seeing B lines. And what we're seeing really is these bright lines coming down from the pleura. And these are also a type of reverberation artifact. And what they're creating is these small little spotlights coming down from the surface. And so you can actually see in this image, there's numerous, right? A bunch of these bright lines coming down, also in this rib space here, and these represent fluid. In this case, this was a patient with congestive heart failure, but remember, B lines just means fluid. So here's another example of B lines. You could see multiple hyperechoic or bright reverberation artifacts coming down here from the pleura. And this is what we'll see in anything where there's fluid in the lung. So pulmonary edema, pneumonia, COVID-19, atelectasis, all of these different pathologies will cause B-line patterns. And it's really what the distribution of those B lines and also the clinical correlation that help us figure out what's going on. So I want you to remember that air equals default. Right? We don't always see A lines. I'm not always going to see A lines. But if I don't see B lines, then it's automatically an air pattern. Does that make sense? Because depending on the setting of the machine you're using, they may not show you nice, pretty A lines. But if you don't see them, then that's an A line pattern by default. So what about some other artifacts? I always like to show these because I don't want you to confuse them with B lines. So these are called I lines. And if you don't want to remember eye lines, you can remember comet tails. And what these are these little tiny artifacts. Do you guys see these little tiny vertical things that are appearing and disappearing? Those little tiny artifacts. Those are actually normal. Those are actually from microfibrosis of the pleural line. And they're not pathologic, and they're not B-lines. So the things that distinguish them from B-lines is they do not reach the end of the screen. Usually I like to have about 10 centimeters down on my screen. And they do not obliterate A-lines. So that's an important point. I showed you guys A-lines and I showed you B-lines. You notice, right, that they didn't coexist. Because if you have a true B-line, you can't have an A-line too, because that wouldn't make sense. How can you have air and fluid in the alveoli at the same time? So here's an example of B-lines compared to your comet tails, right? So keep those two separate. So comet tails, I-lines normal, B-lines pathologic, fluid. Last artifact. You put the ultrasound probe on someone's chest, and you see this. Anyone have any ideas? Yes, sub-Q emphysema. So all of this, air is going to be really bright on ultrasound, and it's going to basically obscure everything we see below it. So if you put an ultrasound on someone's chest who has sub-Q emphysema, all you're going to see is hyperechoic areas in the soft tissue, and it's going to completely obscure the remainder of the image, because air, right, is ultrasound's worst enemy. And as soon as it hits air, we've lost our entire picture. So it's above the pleura, it's above the ribs, and that's why we don't see anything. So subcutaneous emphysema is going to arise above the pleura. It's going to obscure all imaging. So you can see on the right, there's our nice pleura with multiple A-lines, and on the left, nothing, right? So really, lung ultrasound, and what I really want to hit home today is that it's really just a piece of the puzzle, right? Anything we do with lung ultrasound always has to be clinically correlated. So it's just one tool. I'm not doing it in a black box. I'm correlating it clinically. I'm looking at the pattern of distribution of my A-lines and B-lines, and I'm using that to figure out what's going on. So let's talk about some cases. So this was a 70-year-old with COPD who presented with acute shortness of breath and chest pain. It was right-sided chest pain. We decided to put the ultrasound probe on there first, and this is what we saw. What do you guys think? No lung sliding, right? Yeah, here I heard that. If you guys look, remember our classic pattern, right? Remember, rib, shadow, rib. Not rib, shadow, rib. Rib, pleura, rib. You can see our pleura right here, what we think is, which is actually not pleura, but we see it's not moving. We just see a bright line, and we see no movement at all. So that was a pneumothorax. This patient actually ended up having a very large pneumothorax from a ruptured bleb and ended up getting a chest tube. So when we're looking at pneumothorax, and we're seeing no lung sliding, it's going to be helpful to tell us that there's a high likelihood of a pneumothorax, but it's not definitive. So we are going to be looking for something else called a lung point. But to understand what causes this finding on ultrasound, I want to look at this image first. So on the left side, you see when I put the ultrasound over the side with the collapsed lung, we're hitting air first. And just like I told you about that sub-Q case, once you hit air, you just see a bright line, right? And it reflects everything else. So we see nothing else below it. So that's why you get no lung sliding. That line is not the pleura, it's just a line of air. And when we put it on the other side, that line that we're seeing sliding back and forth is actually the parietal and visceral pleura rubbing against themselves, right? So they're moving back and forth. So I want you to remember that no sliding suggests a pneumothorax, right? So like this. But a lung point is pathognomonic, right? So now, if I take the same case and I move my probe down to the side, where I can see part of the lung is up and part of the lung is collapsed, that's telling me this is definitely a pneumothorax because I know exactly where that lung point is. So if we look at this image, pay particular attention to the right side of that pleura. You can see we can see the pleura coming in and out, right? Do you guys see that? Look at the left side. There's no sliding there, right? That's just air. So that is our lung point. We see lung sliding on one side, air on the other. And so if you're unsure if there's lung sliding present, you can use something called M mode. Deja talked about that with cardiac ultrasound for EPSS. So if we just put that M mode cursor right through that pleural line, you can see I've highlighted the pleural line in blue arrow at the top, and also on the M mode screen below, that's the pleural line. So everything below this would be where the lung should be. And you guys can see as it moves back and forth, it creates what we call this sandy beach sign, or sandy seashore. I forget exactly what the terminology is. But it's like a sandy beach, and that's because the pleura is moving back and forth, and it's creating this pattern. Now, if there's no lung sliding, what will happen is it'll just look like a barcode. Because you can imagine if nothing's moving, then those pixels will just kind of carry out and look like straight lines. So on the right is a pneumothorax. We see just straight lines below the pleura. And on the left is a normal lung sliding. We see the seashore sign. So here's a quick quiz. Which side is normal, A or B? A is correct. So you guys can see we have actually some comet tails. And I forgot to mention, if you see a comet tail, that also rules out a pneumothorax, because you can only have a comet tail if you have pleura sliding. And then B, we can see the pleura is not moving at all. Now, sometimes you might notice some movement of the pleura up and down, and that's the patient breathing and their intercostal muscles thickening. And so you see a little bit of rising, right, as the patient breathes, but that doesn't tell us anything about the pleura. What about this one, A or B? Oh, they're kind of moving around a lot. There we go. A, right? Pleural sliding on that side. We have no lung sliding in B. No movement. A or B? You guys are becoming experts by now. A, there is lung sliding in A, and there's no lung sliding in B. M mode quiz? Which one's normal? B. Yep, sandy beach right here. And we can see the barcode sign, so no lung sliding in A. Excellent. So what about this case? This was a 57-year-old with COPD and a heart problem who presented with acutely worsening shortness of breath over the past few days. We take the ultrasound, we put it on their right chest. We see these. What are these? B lines. We put it on their left chest. We see these. So bilateral B lines. We take a look at their cardiac activity. What view is this? Parasternal long. Good or bad? Bad. So yeah, this is a severely reduced EF. And then we look at their IVC. It's plethoric. It's not moving. Right, so we pretty much have the diagnosis, right? What does this patient have? Congestive heart failure exacerbation. We have diffuse pulmonary or diffuse B lines, poor EF, a dilated IVC. I mean, this seems pretty consistent with pulmonary edema in the setting of congestive heart failure. Yeah, so this is a pretty easy case, right? We give them nitro, we diurese them. They were admitted, they were requiring oxygen. But pretty easy with ultrasound, right, to figure that out. So how do we actually diagnose acute heart failure? There's specific criteria we look for, and I think we kind of just reviewed them in that case, but let's go over them again. So we're looking for B lines bilaterally. I like to look for at least 3 B lines per intercostal space in at least 2 spaces on each side. So I want to see B lines in 2 different intercostal spaces on my right, and then at least 3 B lines in 2 intercostal spaces on my left. I'm usually looking anteriorly and then sliding laterally. Decreased EF and a plethoric IVC. If I have all these 3 things, right, I'm pretty much a slam dunk, right? One caveat here, right, is what about our diastolic patients, right? A lot of them have normal EF. So if we just went by these criteria, we probably would miss some patients with diastolic heart failure. I'm typically also looking at their left atrium. If their left atrium is greater than 4 centimeters, that's a clue to me that they have diastolic dysfunction. There's also more advanced techniques that we can talk about for diastolic dysfunction. I think Jacob's going to mention them tomorrow. But that is an important thing to remember, that if they may still have a normal EF, but they may be having a diastolic heart failure exacerbation. So you have to think about that. Our third case is a 65-year-old with cirrhosis presenting with increased shortness of breath over the past week. So we decided to do the standard workup. We get the chest x-ray. This was their chest x-ray. What do you guys think? It's not that impressive. We see something on the right side. Maybe there's a small pleural effusion. That's what it was read by as radiology. So we decided to do our cardiorespiratory ultrasound, right? So here's our cardiac ultrasound. Looks pretty good. Peristernal long. We can see that anterior leaflet is hitting the septum, right? So that's a normal EF, good squeeze. The rule of thirds that Deja talked about applies here, right? The RV, the aortic outflow, and the left atrium are all about the same size. So it's normal. We look at the lungs bilaterally. What pattern is this? A or B? It disappeared again. There it is. A pattern, so air. And then we look at that right lung. It's way bigger than that x-ray said, right? So this was a really large pleural effusion. The patient just needed a thoracentesis. So they got their thoracentesis and they were discharged home. The point I want to make here is that x-ray significantly underestimates pleural effusions. A lot of times you'll be scratching your head, trying to figure out why they're so short of breath. The x-ray only read a small pleural effusion or atelectasis. You'll see that read. But really, it's a big pleural effusion. So ultrasound adds so much value when we're looking at pleural effusions. So anytime I see anything at the lung bases, I'm always taking a look with ultrasound. So here's where we look for ultrasound, for effusions with ultrasound. So again, right at those costophrenic angles, we're going to put the probe in an axial orientation. And what we're looking for is fluid just above the diaphragm. So in this image, you can see liver, diaphragm. There's spine, is this hyperechoic line going posteriorly. And then there is the pleural effusion. It's going to be anechoic. It could be hypoechoic if it's complex or have loculations. But let's compare this to no pleural effusion. So you can notice two things on this normal one. As the patient breathes, do you guys see this? As it comes in, this A lines. That's called a lung curtain. So that's normal. So when someone breathes down, right, their lung is coming down and it's full of A lines, air, and so it's obscuring the image. Well, that's normal. The other thing we notice is look at the spine. When we're looking at an effusion, that spine extends into the chest. So we know that there has to be a pleural effusion there. When we look at a normal lung, the spine stops at the diaphragm. And that's because, remember, there's air in a normal lung at the base, so we should not be able to see through it. Once it becomes pathologic and there's fluid there, it now creates a pathway for that ultrasound to come down, and that's why we see it. So a spine sign, which is what this is called, equals a pleural effusion. So that can be a clue to have you evaluate that base more. Case 4, this is our 45-year-old that presented with cough and fever for 1 day. COVID test was negative. So pretty normal. It's a healthy person. They ended up getting an x-ray, told they were fine. They went home, but they did come back the next day, and this was their chest x-ray. What do you guys think about this one? Yeah, pneumonia. So this is a bacterial pneumonia, and I really didn't want to say that the ultrasound necessarily would have picked it up before. That's not the point I'm trying to get across. I'm just trying to show you what pneumonia looks like on ultrasound. So this is actually what that infiltrate looks like. So this is the one time, right, when you're actually going to start to see the lung parenchyma. Remember I told you lung ultrasound is artifact? It's no longer artifact, right? Because now that air is all gone and that lung is consolidated down, you can actually see that lung. So what we're actually seeing here is this is all lung that's consolidated. Do you guys see these white little dots that are moving back and forth? That's air. So these are actually dynamic air bronchograms. So this is air trapped in that consolidated lung moving back and forth. So this patient ended up, they were kind of sick looking and ended up getting admitted, got antibiotics, did well. So let's talk about some pneumonia findings. So like that finding I just showed you, dynamic air bronchograms are going to be pathognomonic for pneumonia. Here in this image is another good example. You can see all of this lung here is consolidated, and we can see those bright lines. They actually nicely outlined the bronchi here. So these are actually dynamic air bronchograms, kind of like a Christmas tree pattern. Other things we might see is something called hepatization of the lung. And this is when that lung, again, becomes so consolidated, it starts to look like a liver appearance. In this case, it does look like liver, except it's got these hyperechoic spots in it, which is actually some air that's trapped in there. So this is a consolidated lung, and this is called hepatization of the lung. And lastly, we may also see something called a shred sign. And this is when that pleura becomes shredded down. So this is a pediatric patient. Do you guys see how many pleura rib spaces there are, right? There's 3 different ribs, 1, 2, 3 different pleura spaces. But the pleura line, you can see it right there on the right side of the image, but then do you see how there's like a chunk taken out of it? The pleura is shredded. So it's shredded down, and there's actually something taken out of it. You also would call this a subpleural consolidation. And we can see subpleural consolidations in a variety of things: pulmonary embolism, viral pneumonia, bacterial pneumonia. Generally, when we have very large subpleural consolidations, they're more indicative of bacterial, whereas small subpleural consolidations are more indicative of viral processes. But again, like I said, we always have to be clinically correlating, because we don't want to think we're seeing a pneumonia when it could be a finding of someone with a PE. So always taking the clinical history into account. And our last case was a 50-year-old with acute shortness of breath for 1 day. So she came in, she just really felt short of breath whenever she walked around. Never really had anything like this before. Here's her lungs bilaterally. What do you guys think? A-lines, right? So air, and we also see lung sliding at the top, kind of shimmering. Here's the pleura base bilaterally. Nice lung curtain, right? So that's a normal base. We can see the patient breathing and kind of covers up the image. Well, we did a little cardiac ultrasound, and this is a parasternal short. What do you guys think about this one? Yeah, I hear RV is big. Yeah, what we're seeing is, just to kind of orient you guys again, this is the left ventricle, this is the right. And look at this, this is a normal parasternal short, right? That LV actually bows into the RV because this is a higher pressure chamber. But look at that, this septum's bowing the other way. So this patient actually had RV strain in the setting of a PE. So we saw this, they were hemodynamically stable, so we took them over, got a CT, and confirmed that it was a pulmonary embolism. It was submassive in this case because they had right ventricular dysfunction. They ended up doing well. They actually just got anticoagulated and was discharged 2 days later. So the actual name of this sign is the D sign, and that's really what we would see with right ventricle strain. And this may be from a PE. It could be from pulmonary hypertension, but it's when the RV is pressure overloaded. So ultimately, hopefully you guys have seen in those cases, right, it's really about cardiac and lung ultrasound, right? We're not doing just a lung. We're not doing just a cardiac. We're really doing a cardiorespiratory ultrasound. So again, I'm rarely doing one and not the other. So I really just want to take home a few points. I hope that I've showed you over this past 30 minutes the lung ultrasound is better than chest x-ray, but that doesn't mean that I'm not getting chest x-rays. I order chest x-rays on a lot of these patients, right? but I'm adding ultrasound to it. I think there's value, and I really find that it helps me. A standardized approach is really the best for these cases. I feel like if you start skimping and just trying to look in one place or another, and because you think you know where you need to look, I think you're going to miss things. So really have a standardized approach. I'm going to look anterior, lateral, I'm going to look at the bases, I'm going to do my cardiac exam, look at my IVC, or do my posterior. Whether you do those or not, those can be a little bit challenging depending on your patient, but have the same approach every time. And the last thing, and I think the most important, is just like anything, right? Never interpret lung ultrasound in isolation. You always want to use it correlated clinically. You always want to take it into account with the patient in front of you. Any questions? Yeah.
So as B-lines are an artifact, there's no way to tell how deep fluid might be anywhere over that down the reach.
Yeah, no, we can't tell how deep they are, but essentially we're knowing that that area of alveoli underneath, directly underneath where we're looking, is full of fluid. Usually I will put it at around 10 to 12 centimeters. I bet if we kind of polled all of the different faculty here, they probably have different numbers, but you don't want it too shallow because you want to be able to see far enough that you actually see if they're true B-lines. You don't want to confuse them. If you're really close on the pleura, you might confuse comet tails with B-lines. So I like 10 centimeters, 12 centimeters, I think is a good rule of thumb.
For the pulmonary edema criteria for B-lines, it says 3 in at least 2 zones on both sides. So you mentioned 3 in 2 intercostal spaces. So is that a total of 3 between the 2 or 3 in each?
Good question. Yeah, so when I call it I'll basically like, is it a positive intercostal space? So if I see 3 in one space, then that intercostal is now positive. So I would say, I would look at 2 intercostal spaces. If each one has 3 lines, those are each positive. What I didn't show here, and now I'm going to add to my next slide, is sometimes you have so many B lines that they actually become confluent, and it just looks like white lung. And maybe we can add it on a later lecture. But white lung is when you have so many B lines, the whole lung is just white, and that's confluent. So that suggests significant fluid in that area.
Does lung fibrosis have similar B-lines, or does it also?
Pulmonary fibrosis, you'll also see B lines. Yep.
You can't distinguish the characteristics just based on that. I mean, is it just based on the distribution or?
Distribution is going to play a big part, and we didn't, there's a whole next level on when we're talking about, we could talk about COVID, and COVID sort of messes up the whole thing because we have B lines here and there. We have a regular pleura. We have actually what looks like B lines and A lines coexisting. There's all sorts of things, but pattern is going to be important. And then the pleura will play into, for example, the fibrosis. They should have more pleural changes with their B lines. So that's kind of a weak answer for that. But basically, yeah, there's a lot of other factors. So I kind of wanted to set, these are the big distinctions we can make. And then depending on the pattern, the distribution, and the associated findings, that will kind of help clue you in more. Oh, you got an example?
Yeah, for the pulmonary fibrosis question, I'm Matt, by the way. I worked occasionally in Navajo Nation where there are actually uranium miners who have fibrotic lung disease, and they come in, and it's clinical context, which Mike said in his talk, right? So if you have
that's a good one.
If you have a uranium miner, someone who you think has interstitial lung disease or something, you shouldn't look for B lines. You're going to have B lines everywhere. And then if they sound like they have COVID, you see COVID lung. It's different. So again, doctor first, and then the ultrasound just helps.
That's a great image.
I'll just put on a loop real fast. I just tried going there, not at all. You keep talking.
Oh, just play it. Is it connected?
Well, it doesn't. Yeah, but it doesn't loop, which makes it suck a little bit.
Oh, that's okay. I'll just replay it.
Here.
Oh, I see what you're doing.
Yeah, you know what I mean?
Hold, please. Yeah.
Logistically, just to be more efficient, how do you approach it? Do you do the zones with the linear probe and then switch to cardiac? cardiac probe?
I generally, because I like to be efficient, I do everything with my cardiac probe. So I do it all. I don't like to switch probes. I think there was a debate on Twitter not too long about what's the best probe for looking at lungs, and curvilinear with abdominal preset has supposedly been deemed the winner. But I'll do a cardiac, and I'll do my cardiac peristernal actually first, and then I'll look at my anterior, lateral, including my pleural bases. I'm not going to lie, I don't always look at the posterior aspects. If I'm thinking COVID, I check out. If you can't sit the patient up, you can actually look at the posterior places by laying them down and having them turn and hold the rail. Because if they're older and they can't sit up very well, you can have them roll to the side. Okay, and there you go. So this is confluence. See, this is just tons of fluid in these alveoli. So you can see that all the B lines have fused, and all we're seeing is just white lung. So white lung equals just significant fluid there. Cool? Jacob?
There's like a couple other factors too. With pulmonary fibrosis, who asked that question? Sweet. So you'll have traditionally a really we call it a thickened pleural line, which is a misnomer.
Pulmonary fibrosis.
Actually, the pleural line is not a real pleural line. It's actually an artifact, by the way. But it's going to be a lot thicker, way more irregular instead of like a nice line. You'll see V lines, but the big thing is the thickened irregular pleural line, and then you might actually see subpleural nodules, which is just like almost like a border circular, like cyst-looking structure that's kind of ill-defined. Those are the two findings that are thought to be more specific for a pulmonary fibrosis, sclerosis type picture. But a lot of it is doctor first, right? Do they have that or not? And if there's someone that comes in and you're like, they have weird ratty lungs, could it be COPD and heart failure? You just add things. So I'll add the IVC, I'll add the heart, and put all those three things together and then think, this is my best guess. I think it's heart failure.
So yeah, I think I've heard about that before, where you look at the irregular pleural line, if you see any subpleural consolidation. I think you guys mentioned in one of your videos I watched before, and then if it's a little bit more patchy, if it's not diffuse and like the ground glass, the key line is a little more patchy. Is there anything behind like looking at the distance between the key lines?
No, don't do that.
I think one of my attendees mentioned that before, where I think we were doing a lung ultrasound on somebody, and we were trying to figure out if it's like ARDS or pulmonary edema. And he mentioned something from, I think, Lichtenstein's book about measuring the distance between the B lines and kind of help guide you. I don't know if you guys have heard of that before.
Yeah, so Lichtenstein, what's that?
I want to repeat the question.
Sure.
Back here for...
So the question is, if I may, is that there's this guy who is like the father of lung ultrasound. He invented lung ultrasound. Nobody was doing lung ultrasound and before this guy did it, right? So we owe him a huge debt of gratitude because he's a guy that taught us we could do this, right? His viewpoints on it are his viewpoints, and he's an ICU doctor in France. Great guy. His name's Daniel Lichtenstein. The problem is that his results some of them don't seem to be have external validity. So it seems like outside of his patient population, other people can't do that same thing with accuracy. So his thing is he says that if they're like 3 centimeters, or it might be millimeters, 3 millimeters apart or 11 millimeters apart, that's how they tell the difference between lobar fluid versus alveolar fluid, which is insane. Can you imagine if everybody's lungs were a perfect hexagonal shape, exactly the same amount of space between every single interlobular septa, every alveoli was exactly this space. It's not how things work in real life. There's no CT scan or histologic evidence for what he's saying. So I know that works really well for him, but I don't believe that kind of stuff as far as the distance between them being the thing that correlates it, if it's one thing or the other. What I do think is that the more B lines that you have, the more likely it's in the alveoli. So his kind of point makes sense, the closer they are together, the more likely it is to be in the sacs versus just in the lobular septa. That makes perfect sense, but measuring them out is not something that really is supported by all of the available literature apart from his ICU in French. Does that make sense? I love the guy, by the way. I've met him. He's really nice. But I think reasonable people can disagree, right?
Thank you. All right. Any other questions?
Just real quick, do you train all the heartbeats every time?
Man, you guys are really, wow. Am I supposed to give the honest answer? Every time now. Again, I think ultimately what you'll get down to is when you start doing ultrasound a lot is I'm going in, I already know the question I want to answer, right? I already know why I'm looking, or generally. And so if I can answer that, like sometimes I just want to know if there's an effusion or not. If I can rule that out in one view or two views, then that's fine. Sometimes it does take all three. So yeah, I think the truth, honest answer is that it really depends. I think it's good when you're getting started to work on all of them, because if you ignore one of them because it's difficult, then you'll never learn it. But yeah, not always. Not always for cardiac. For lung, generally I do. I go down, I go down, I go over, I go over. I mean, the same thing every time. But for cardiac, yeah, it really depends on my question. All right, thank you, everybody.